Hello everyone, my name's Rachael Lowe, I'm from Physiopedia and I am completely honoured today to be talking with Professor Gwendolen Jull. Hello Gwendolen.
Hello Rachel.
Thank you so much for joining us today. I have contacted you to talk to you about the cervical spine, and your contribution to the neck pain literature has been phenomenal over the years. And I was doing a little bit of reading before we spoke today, and I see there are 6 books, over 20 book chapters, nearly 300 research articles. I don't know how you've done all that in your time, and I don't know where to start with questions to ask you. So I was wondering if you might be able to, first of all, just tell us a little bit about yourself. I'm sure most people listening to this will know of you already, but there are perhaps some people who haven't come across you. So maybe you could tell us a little bit about yourself and the work that you've been up to.
Well, Rachel, I've done a fair bit of work, but I've now been around for quite a long time. So I graduated quite a number of years ago. For the first about 6 or so years, I was in clinical practice and travelled. And then I came back to Australia and had the great fortune of studying under Jeff Maitland for about a year and a half. And I suppose that's what really launched my whole interest in the musculoskeletal. And then after that, I was offered a position at the University of Queensland. And even though I was there for a long time, it was very, very varied and it changed dramatically over the years. But basically, I was teaching in the musculoskeletal field in the undergraduate area. In 1990, I developed the first masters in manipulative therapy at UQ. It was pretty obvious with teaching that you needed to keep your hand in clinical practice. So I've always, through my whole time at uni, done private practice part-time. And then, of course, there's the research. And I headed the cervical spine and whiplash research unit at UQ. And we had various interests in, looking at manual therapy, most importantly, looking at neuromuscular function in neck pain, as well as sensory motor function, and looking at ways that we could more specifically actually treat the neck. So knowing what was going wrong with it, we had a research base which informed the development of different sort of therapies, basically.
So in all that time, with all those researchers and all that work, what do you think, I want to ask you, what are the sort of main concepts that have come out of your work that you think have impacted clinical practice and the sort of our management of individuals with neck pain?
Well, I would imagine that it's the work in neuromuscular function and dysfunction in neck pain. As I said, I've practiced clinically and so I did my manipulative therapy training and I was very much a manipulative therapist, but you realise that there was something missing. And what was missing really was rehabilitation. So you could treat the pain, and manual therapy is still an excellent modality to treat neck pain, but it doesn't automatically make the muscles work again, etc. People had been doing neck stretches and strengthening for many, many years, but we also felt that that wasn't the answer either. And I was working with Carolyn Richardson at the time, who was very interested in stability and deep muscles. And we also had a visit at that time by Professor Yander. I don't know if you know him, but he was a Czech musculoskeletal medicine doctor. And he, again, was interested in muscle imbalances. And he was the one who developed these syndromes called the proximal cross syndrome, etc. And so he kept saying your deep neck flexors are most critical for your support of your neck, and you should be looking at those, and etc. So that's where we started, was to start differentiating between activity in the deep and superficial muscles. And indeed, we found these imbalances and changes in muscle behaviour in the deep versus superficial. So that's where we started and developed clinical tests, and then developed treatment regimes where we could focus more on different muscle layers for a complete rehab type setting, and then have done several clinical trials as well. But I would say, if you say, well, what's my contribution? I should imagine it is in the therapeutics. I still strongly advocate a multimodal treatment program. And also, what I see happening at the moment is that we haven't lost the concept of rehabilitation for the lower limb or the upper limb, for example. You know, if somebody injures their knee, we're straight in, we'll give them a full rehabilitation program. Or, for example, if somebody tears their anterior cruciate ligament, we expect them to have 3 to 6 months rehabilitation. If somebody injures their neck, they're supposed to get active, go back to work, and don't need anything, a session of advice. I mean, what is happening between the management of extremity disorders and what is happening in the spine is, I find incredible that there's such a huge gulf between the two. Whereas in reality, you know, what happens in the lower limb, I mean, if you hurt your knee, you get proprioceptive deficits, you get decreases in your muscle strength, etc., etc. The same thing happens, you know, in your neck and in your back. But we've just gone a bit off track, I think, and I think it's about time we started getting back on track and rehabilitating people.
So there's a couple of things that I want to ask you from that. The first is, and I hope I'll remember the second in a minute, the first is, why do you think that's happened?
I think we're getting, there's a lot of emphasis on pain, and there's a lot of emphasis, we've gone into the biopsychosocial model, and so people who were more biologically orientated were accused of you know, not being in that whole biopsychosocial model. But at the moment, I almost think there's almost a splitting that we're getting, people who are going purely into the psychology and forgetting the biology, or they think that just treating pain is the beginning and the end of it all. And it's not. It's not. Just getting rid of pain or even calming pain doesn't rehabilitate function.
And that leads into, I guess that's when you say that you advocate for a multimodal approach to managing neck pain. That's where the two sides of the picture come together, isn't it?
Yeah, yeah. And I mean, all parts. You must treat pain. If a patient is anxious, you must help them, relieve them of their anxiety, etc. We've got to treat the patient as a whole and not segment them into various areas. And also, I think a lot of the work is coming out of chronic pain. And when you think about it, for the average physio working in a private practice, for example, they don't see many of those patients. I mean, I worked in practice for 40 years, and the real chronic pain is, I was in a suburban practice. Well, I never saw them. Now, if I happened to work in a hospital, in a pain clinic in a hospital or something like that, they would probably be my bread and butter. But in a normal sort of outpatient department, you know, there's only I hate to put numbers on it because it really is highly variable. But if you take idiopathic neck pain, there's probably only about 5 to absolutely at the maximum 10% who have major psychosocial issues. You know, when you think of the whole spectrum of neck pain, and we seem, I think, to have got a little bit into chronic pain, and then what we're finding in people with the genuine chronic pain who do have a lot of problems. I mean, it'd be awful to have that really nasty chronic pain, but we're tending to want to extrapolate what happens to them to every single neck pain patient, and it's just not like that. It's just not like that.
And that's where it's really important to treat everyone as an individual, isn't it? We look at when we're looking at someone to treat them specifically as an individual, look at their particular symptoms and how we can their presentation and how we can address that specifically for them and their context and situation and goals, I imagine. So So you talked about sort of a multimodal approach to that, to the individuals that with neck pain, and if we're thinking more of the sort of not the non-chronic type of pain, what sort of interventions do you think we should be using for neck pain? And in a way that so for clinicians out there who are listening, who would like to take something into their practice, straight away, what are the sort of things that we should be focusing on individuals with neck pain?
Well, the first thing is to, as you mentioned before, get a thorough understanding of them as an individual and what their expectations are of treatment and where, how they see they might progress and what are their goals. I think hands-on is extremely important, even though we often have this ridiculous hands-on, hands-off debate, which you probably shouldn't get me started on. Good. You need to put your hands on a patient. I mean, the thing with spinal pain patients is that they need to have their condition validated in a way. If you sprain your ankle, it's there for everybody to see, everybody believes you, etc. But often with neck pain, you look quite normal. And one of the ways to really validate it is that, to put your hands on the neck, and physios, a skilled manual therapist can detect the segmental sources of pain. So whether you want to use manual therapy in your management, I think to do a thorough physical examination is very, very important, because it really does build that trust between the clinician and the patient can then be assured that you in fact do know what's going on with their necks. So personally, I use manual therapy. I mean, there's evidence of effectiveness, particularly in the cervical spine. It's one of our best pain relieving techniques. But then I'll base the rest of my treatment on what else do you find. So a joint is never going to get painful or anything like that without reactions happening in the muscle system. So you can almost predict the types of things that you might find. There's a lot of symptoms that cervical spine patients may complain about, such as lightheadedness or unsteadiness. And there's tremendous work being done by Julia Treleaven here looking at sensory motor deficits in association with neck pain. And again, you can do some very, very simple tests to display them, and then rehab strategies. And the rehabilitation strategies aren't overly sophisticated, and they very much follow a vestibular routine. So it really does, when I say multimodal, I want to look after the patient. I want to find out what's happening in their various physical systems. I certainly want to get an appreciation of any anxieties or fears or anything like that I can deal with. But I might add that we shouldn't, I also have a dislike for the word maladaptive, because often if you've got a very sore neck and you don't understand why you've got it and you don't know what's going on, it is very, very normal for you to be anxious about that. So that's a normal reaction. It's not a maladaptive reaction. It's a normal. And so it's finding out those and with assurance and explaining what's happening, you can relieve anxiety within 5 or 10 minutes some of the time. So it's just treating the patient as a whole rather than try to get into one tiny little area.
So you mentioned some of the key things, I think, key skills that we have as physios there, the importance of the assessment, and that's where, and communication comes into that, doesn't it? And then that also, that leads into education as well, which you just mentioned, which can help to alleviate anxieties and fears and things like that, and then, make a more positive pathway, so to speak, for future rehabilitation. And you also mentioned manual therapy and the importance of that. I just want to come back to the rehabilitation side of things. So for your work, a lot of your work has been on the deep muscles of the neck. What sort of With regards to rehabilitation of the cervical spine, if we're going to try and encourage physiotherapists to pay more attention to rehabilitation in the spine, like we pay a lot of attention to that in the knee and things, as you've already mentioned, what sort of advice would you give to clinicians now to integrate more rehabilitation into this for individuals with neck pain?
I would say to them to start with, for every patient who with neck pain, that they don't start looking at their muscle system and starting to re-educate it. That it should mean that every patient who comes in with a sore knee, they never, ever, ever give them a quads exercise. It's illogical for them not to actually look at the muscle system. The tests that you need do are not difficult, and we get them to do, the key tests are the craniocervical flexion test, which is basically your chin nod test to test the activation of your deep neck flexors. You must look at the extensors because the research is not as extensive into the extensors. They're a bit harder to research because there's 5 different layers. We're lucky in the front there's 2, so it's easy. But in the back of the neck, it's a bit harder. But the research that's starting to come out is showing that probably the same sort of thing is happening there, that your deeper muscles like semispinalis, cervicus and multifidus are getting weaker, relatively more weak than your, I don't know if that's good English, relatively weaker than your superficial muscles. I mean, all of the extensors, for example, get weak. All of the flexors get weak, but you get this imbalance in the amount of weakness between the deep and superficial muscles. So that you can, to examine the extensors as precisely as you can examine the flexors, it's not as easy. But you can, by just getting the patient, say, in a 4-point kneeling position or prone on elbows, if they keep their eyes looking at the bed and then they just do a chin extension, that will get rectus capitis posterior, major, minor. And if they just do the C1-2 rotation, that gets the obliquus capitis superior and inferior. In other words, you've just tested the suboccipital muscles. And most of the research, anybody who's got an upper cervical problem, they almost inevitably will get wasting. All of the studies that have either with an MRI or ultrasound have shown that. So sometimes it's difficult to see a real disturbance in the clinical situation. Like the patient can do it because it's a familiar activity, but I do that routinely and I get the patients to exercise that routinely. And then for the extensors, if you want to try to bias the movement towards the deeper extensors, you ask the patient to extend, but to just keep their head in neutral. So in other words, when they extend, they can't lift their chin up, they just take their whole head back. And if you ask them, for example, the cue we give, if you can imagine your patient in 4-point kneeling, we put a book between their hands and say to them, okay, roll your head backwards, but keep looking at the book. And the eye facilitation down actually keeps their head in a neutral position. And you often find you pick up weakness in the extensors quite readily. And so as far as the rehab is concerned, that's where I'll start, is exercising in the craniocervical flexion training and also in that neck extension training. And then once they get stronger, it's to keep in mind that the superficial muscles also get weak. And so you've eventually got to progress the program up to strengthening all the extensors and strengthening all the flexors, plus or minus axioscapular muscles as well.
Yes, of course, looking at if we're talking about kind of quadrants, when we talk about quadrants, when we look at the lower limb, the knee, we always go up to all the way up. So maybe we should be doing that from the spine down as well.
Sure.
Yeah. So when you, we've talked about, so it makes me think of a couple of things. When you're doing those tests, it's difficult, isn't it? Because in the knee, for example, when there's a knee pain or a knee injury, then it's obvious that the quads have, are less active, and that's difficult to see in the neck. So we do need to look at those tests, and you've described some really nice tests there that people can use to assess, and you mentioned that you may see weaknesses in those tests.
Well, what happens with the craniocervical flexion test, I mean, we do use that pressure biofeedback because it is difficult to see and you can't feel these muscles, and neither can the patient know what they're doing, and that's why it's the patient who needs the feedback. And so that you'll find that your normal patients, we pump it to 20 and we're looking at that 22, 24, 26, 28, 30. Your normal people can easily do 26, 28, and many of them can do 30. Whereas you find that your neck pain patients, some of them can't even do 22, and the rest of them struggle around that 24 mark. So that's easy to pick up. With the extensors, as I said, if you do just the head extension and head rotation, you don't pick up much. But when you're doing the neck extension, keeping that head in a neutral position, what you find is that normal people can extend at least about 30, maybe 40 degrees above the horizontal. Whereas what happens with the neck pain patients, many of them can't even extend past the horizontal. Or if they can get a bit further, within 5 or 6 repetitions, they're telling you they're fatiguing. So the extensors is not so hard to pick up.
So that's some really good tips on how to use those exercises, or I want to say movements, as a test and as rehabilitation.
Yeah.
Just moving on to the larger, more superficial muscles, when you move on to a more global rehabilitation, have you got some key exercises that you've found worked really well with patients?
Well, for the extensors, we leave them in that 4-point kneeling position or prone on elbows, whichever you've got. And a lot of people ride bikes these days, bicycles. So even just getting them to put a bicycle helmet on, even though it's light, you can start giving them resistance. So we just build up resistance in that position. Now, you can use TheraBand if you want to, but the only problem with TheraBand is the hair is slippery, so it's often hard to stay on. If you've got a pulley system, you can get a headband and they can strengthen that way. Why I have a preference for doing it with bike helmets and then just putting little weights on the bike helmet is that it's easy for the patient to then take it home. If you set them up with a pulley system in your department, in your clinic, well, they haven't got that at home. So, I mean, that's the important thing. The amount of exercise that they're doing in the clinic is not a sufficient dosage to get change. So everything that you do in the clinic's got to be translated into a home program, and so it's got to be easy to do. I think one of the things I've learned as a factor of age is to keep it simple. And the simpler you can make it, the more chance, because you can have the best exercise program in the world, but if the patient doesn't do it, it's not going to help. So it's terribly important to make the exercises simple, easy to do, and convenient to do. And then you've got a much better chance of getting patients to comply.
Yeah, absolutely, and that's really important, isn't it? There's no point if someone's going to go home with their exercises and not do them, then we're not going to get anywhere, are we? And I mean, none of us are very good at doing our exercises, so the less exercises you have and the simpler they are, the better it can be.
Yeah, absolutely.
And so we've talked a lot about rehabilitation, which is really useful because a lot of your work's been in that area. We've talked about assessment and education and manual therapy. Is there any other, and we've talked about the biopsychosocial approach as well. Is there anything else that we need to have knowledge in or be considering when we're working with individuals with neck pain that's important for us to help them return to function?
Well, for function, but the other thing I sort of mentioned before about pain and almost passed over it, to actually understand pain is very, very important because it has a big impact on the way you'll manage a patient, and also with both whiplash and idiopathic neck pain, it's one of the prognostic features. So to sort of understand that whether your patient has got just a peripheral nociceptive type pain, to try to recognise central sensitisation, and that's where you can get the wider spreads of pain and people become a bit allodynic, etc. Because in those patients, you certainly have to be more careful. So they're the ones that will often stir up with treatment, and you certainly see that in whiplash, and you'll see it in cervicogenic headache, because they've now shown that cervicogenic headache is associated with sensitisation of the trigeminocervical nucleus. And you often, it's not an uncommon complaint that people will say, they went to the physio, but it really stirred my headache up. And it's very, very important in treating anybody with any suggestion of central sensitisation that your treatments are actually pain-free. So, in the good old days, we were taught that you should try to reproduce the headache to prove that it was cervical in origin, for example. Well, that's something now I never do. And when your handling skills get good, you can feel painful joints without having to go strongly enough to reproduce their pain. So pain's very important, and if people have got these high levels of pain and they are very sensitive to movement, your whole rehabilitation program slows down, because you can actually make them worse than make them better. And those sorts of patients with high pain levels, you really have to work cooperatively with the general practitioner or the patient's doctor, because they do need pain management. I've got strong beliefs in physiotherapy, but there is a point that the pain is either too much or its nature is such that really our physical modalities by themselves are not going to be effective. So I think understanding their pain is very, very important.
So how could you give an indication of how we would recognise those individuals that have that level of pain that we need to be really careful?
Well, first of all, they'll have high levels of pain. So they'll be telling you that if you ask them, on the 1 to 10 scale, where are you? They'll be telling you about the 6 or the 7 or maybe the 8. They'll talk about that. Also listen to them. The expression was they were irritable. Okay. And when you think about what's irritability, it is, and that's the quality of a lot of these patients, that they've got higher levels of pain, but if you stir them up, it takes an awful long time to settle. And so even though that's not a scientific fact and all of that sort of stuff, to me, it's makes sense that our old thing of irritability, if you've got a patient whose pain is really irritable, the chances that they've got some sort of augmented central pain processing, I think, is relatively high. So I always listen for their pain intensity, listen to how they talk about movement, how easily their neck is to stir up, etc., how long it takes to settle. They all still give me the guides of how careful I've got to be. Yeah, okay.
I don't want to bring in the hands-on, hands-off debate, but might these be the type of people that we don't use our hands as much on?
Probably initially, because you have got to be very, very careful not to be provocative. And I mean, some of the whiplash patients that you get, for example, some of them can have these really, really high levels of pain right from the word go. And so in those patients, for example, it's probably better to stay hands-off to start with. And they've often got multiple symptoms. So, for example, they may be complaining of unsteadiness and a bit of dizziness, so that you could start some of the sensory motor training which will still have great cervical afferent input going on without directly actually aggravating their pain. So in those sorts of patients, they may be ones that I would keep my hands off to start with. No, the hands-on, hands-off debate more is that you've got this movement who thinks that, or who says that, passive treatments are bad and we should never do them and everything should be active. I just find that a nonsense debate, to tell you the truth. I mean, you need good manual handling skills to actually find out what's going wrong. To me, it's a deficient examination if you can't identify segmental sources of pain, etc. And when you think about it, I mean, patients want it. It's a confirmation for them many times. And I don't know if it's happening in the UK, but it's certainly happening in Australia, that people are, I think, crying out for a bit of hands-on treatment. Our massage therapy industry is booming in Australia, absolutely booming. And that is in this fast world we live in at the moment, people saying, I just want a bit of hands-on, please. And if you're thinking about patient-centered treatment and taking into consideration patient preferences, that even is a stronger debate to put your hands on. And I mean, manual therapy is only part of a treatment. I mean, I have very active treatments with my patients, but it is a very, very good pain relieving technique, which it saddens me to see maybe being lost in some areas of physio.
Yeah, I think, it is a big debate and it can be debated for a long time, but surely it's a balance of both aspects that is specifically catered towards the individual and how they're presenting. And I think, our handling skills are important and touch is very human. So it kind of needs to be an assessment of how much you need to do with the patient for how they're presenting. Would that be correct to say?
Absolutely. And I mean, you will vary treatments and I mean, theoretically, once the patient starts going through the process of rehab, your hands-on becomes less and less as their pain gets under control and you're getting into that rehabilitation phase. So at all different phases and all different stages of patients, you'll do different sorts of things. It's one component, but I think it's a very, very important component.
Yeah, and I think your comments about the massage therapy industry are really, really interesting, because if we are to survive as a profession, we need to pay attention to these sorts of things as well. So that is an interesting side of it to think about as well, I think, for us all to be aware of and have that conversation, I think, as well. Yeah. Okay, well, I'm glad we talked about that a little bit. Let's come back to, just to finish off with the cervical spine and neck pain. What about the future? What do you see? Are there any sort of questions that remain unanswered? Where do you see it going? Is there anything? Do you have any vision into the future for us for treating individuals with neck pain?
Well, I think there's a lot of work to be done. Because I think we've got to stop thinking of treating neck pain, because that gives the thing that which is what is happening. We treat an episode of neck pain, but all the epidemiological studies are showing that neck pain, in fact, is a recurrent disorder, that once you get it once, you have a high possibility that you'll get it over and over again. And I mean, the worst figures that came out was the latest report of the global burden of disease, that study. And neck pain, along with low back pain, is now number one for years lived with a disability. So it's number one out of 310 chronic conditions.
Oh, wow.
Yeah, it's phenomenal. And so rather than just us, this is where rehab comes in, and it's not only rehab, but it's looking at appropriate self-management programs to try to stop, try to at least reduce the recurrence rates, or try to slow the disease progression, because that's what's happening. If you're going to get recurrent episodes all over your life, you are progressing. See, we're doing it for knee arthritis. There are huge, big preventative maintenance programs that slow disease progression, and I think we've just got to go back and say, well, why aren't we doing it to the neck? Because the knee is not number one. Well, admittedly, I think it's about number 8. It's not number 1. The neck is number 1. And so I think there's now got to be a major concentration, not just on treating an episode of pain, but actually rehabilitating the patient enough and then transitioning that into a really good maintenance program. The dentists have been very successful. We all have a daily preventative routine that we incorporate into our everyday life, and we do not think about it. We do it. We clean our teeth. And we've got to have something almost as simple as that we can do for our necks to sort of maintain the health of our neck as well. But I think what I'd like to see is a change in thought from treating an episode of neck pain to treating neck pain, which is a recurrent disorder, and focusing on reducing that recurrence.
Yeah, so almost like long-term rehabilitation that move into a prehabilitation kind of strategy. Is there anyone out there that's doing any work on that at the moment?
Well, we're thinking about it a fair bit, but to actually look at the effects of, we've got ideas, but formal studies, no.
Okay.
But it's got to be a nice young person, because it's a thing that you would really, even a clinical trial, you would need a minimum of a 5-year follow-up. And ideally, you want to start getting interventions in and following them for the next 20 years.
Yeah, absolutely. Yeah. Okay, well, that's interesting. It ties in with practice today and what we're missing in the cervical spine, I guess. Respectful of your time, I don't want to take up too much more of your time, but I do want to ask you, do you have one thing for young physiotherapists out there and older physiotherapists to take into their clinical practice today? I'll keep talking a little bit, for individuals that come to them complain with problems with their neck.
Probably even a more general statement is they've got to enjoy patients. They've got to treat them as a puzzle that they are going to sort out and use their intellect to do it. And they are to try to get as much job satisfaction as possible, and getting job satisfaction is when you get people better. And they've really got, the minute they find themselves getting routine is the minute they should stamp on their foot, go and do a bit more professional development, because neck pain patients are fascinating. They never cease to fascinate me, and the more you know, the more fascinating they become. So I think that's the major. It's to be thrilled. It's to be excited by them. Sounds a bit dramatic, but it's to really enjoy them and enjoy figuring them out and enjoy getting them better. That's what keeps you motivated, I think.
That's such an amazing tip, I think. I've not really heard that one before, and I really like that, and that applies to all physiotherapists across all areas of practice. So really nice to keep in mind, I think. Gwendolen, is there anything else you would like to share with people? Is there anything that we haven't talked about that you would like to mention before we end?
No, I think you've been very broad in the discussion.
Good. Well, that's good. If we've covered everything that you'd like to share, then that's amazing. Delving into your knowledge has been fascinating. I do like exploring and sharing your knowledge with others around the world. Gwendolen, where can we find out more about you, or where can people find out about your work online?
Probably from the University of Queensland website. That usually has a little bit of a summary. Although, as I mentioned before, I am theoretically retired now. I am still doing a fair bit of work, and we're We're writing a second edition of our book at the moment. So I'm actually very busy, even though I'm theoretically retired, but then enjoying it, thoroughly enjoying it.
Good. Well, Gwendolen, I really do hope you enjoy your retirement, and I hope that you get to take some time off for yourself instead of contributing to this massive to the literature that you have contributed to over the years. We're very grateful to you. Thank you so much.
My pleasure.